CataractCoach.com, podcast series episode number 85 with Dr. German Bianchi from Argentina, teaching techniques of cataract and refractive surgery. Welcome back to our Cataract Coach podcast. And today I have a very special guest, my good friend, Dr. German Bianchi from Argentina. And I want to talk to you all about the amazing surgeries you're doing, your travels to teach everyone around the world, and also your own meeting there in Cordoba. Welcome to our podcast.
Thank you. Thank you, my friend. Thank you. I'm very happy to be here with you in your podcast, your famous podcast. Thank you very much. I appreciate so much. Yes.
Tell me,
yes.
How did you start in ophthalmology?
Well, it's a very nice question. I don't have any parents, anything in my family. Anyone was a doctor. I just have to decide because in that time when I was a child, I have a grandmother that always said to me, "You must be a doctor. You must be a doctor." And I started to study medicine, and I love medicine. Well, when I started my first years, I realized that I love the little things. To study with the microscopy, histology, all of these things. I have two options in my in the end of my career, neurosurgeon or ophthalmology, and I decided ophthalmology because I was thinking that maybe it's more comfortable with more happy patients and different life, no? You know. Yes.
For neurosurgery, very few patients say, "Thank you for the brain surgery. I feel so much better." But in ophthalmology, especially cataract and refractive, all the patients say, "Oh my gosh, thank you so much. This is amazing."
Yes. The feedback is so good. You know, the feedback with the patient is very good because usually the refractive surgery, the cataract surgery, the patient are very happy and they leave the glasses and all of the things that we know. No, it's different from another areas like retina or glaucoma. It's different, but in our area, the patients are so much happy. And most of them, of course, most of them. Yes, this was one of the reasons. My sister always said, "I want to be an ophthalmologist when I am studying medicine." And I said to her, "Well, the ophthalmologist is not a doctor. It's not like a doctor. It's just a little thing of the body." Because I didn't think about to be an ophthalmologist. But well, after that, you know the karma.
I think we're so lucky to be ophthalmologists. But yeah, you're right.
Yes.
Tell me about your practice. So you do obviously a lot of cataract surgery, refractive surgery, anterior segment surgery. Tell me about your practice.
Yes, well, I do always, my first practice is cataract surgery and phaco-refractive surgery, and also I do phakic IOLs for high myopes, a lot of them. Well, I do also some surgeries for cornea. I'm specialized in cornea too. This is all of my area. That I work in Buenos Aires. I work in Buenos Aires in Clínica Nano. I started 30 years ago, a long time ago, and I do these surgeries, and I happy with the anterior segment now because well, I used to do all of that things. Yes, and I think many years ago I started with phakic IOL. I think in 2003 I started with the anterior phakic IOLs. I used at that time the phakic 6, but in 2007 I started with the posterior chamber phakic IOL for high myopes like ICL, and then I changed for another one. The name is IPCL. Well, and I continues with like everyone that doing refractive cataract surgery with multifocal EDOF and all of this thing. No? And I also use femto to do cataract surgery. I have the Sept, and when I start with the Sept, I say, well, it's not better than me. It's not better than me. But nowadays, I think it helped a lot for the surgery, and not only for the capsulorhexin. I think is very good for the crystalline fragmentation because reduce the time of phaco, and also for the cataract nuclear 2 or nuclear 1 and phaco refractive, because it's easier than if you do the in the manual way this surgery. No, and I think it's so nice the technology to use nowadays.
Well,
But
for femto, it's kind of dividing. So some ophthalmologists really love femto, femtosecond laser. Some ophthalmologists say really not needed. I've gone back and forth between both sides. I can see the ups and the upsides and the downsides. But I think the one tough part is that for a lot of surgeons around the world, it's a very expensive technology.
it's expensive. I know it's expensive technology. And you need to spend money for its surgery too, because you need to pay for the cassette and all of these things. Well, but also I think that is very useful to reduce the time of phaco. When I start, I was thinking, like you say, that it's expensive and maybe the patient don't want to pay for that. But nowadays, when I offer, many of the patients, 50-60% decide to use the fentanyl. I think it's a very good option in some cases. Of course, I use every week the femto, not just for cataract, for cornea, for corneal rings, for everything.
No,
It's very
it's certainly very useful, especially for some of these complicated corneal cases like the corneal rings or segments, for
I
sure.
know, I know. It is very easy to use the corner ring for in these cases, yes, and it's very helpful too. Yes, but I love the femto. I am in this side, but it helped me a lot to reduce the. Yesterday, I have a very hard cataract, and I did with femto, and I know this hard cataract was pre-cutting. The
Yeah.
time of ultrasound was much less than if I don't use it. And the pre-cutting is very easy to cut the nucleus after the femton. And I think it's very good option to use it. Of course, I feel better when I do all of the surgery, but well, you know, we are, I'm a surgeon, you're a surgeon, and we need to do everything. But I think that technology nowadays help a lot to do a
For,
better surgeries.
for sure. I think we should always embrace newer technologies, at least try them. It's good to have the experience and know how to do everything, have access to all of these. I think, but
Of
what if
course,
when you're a young ophthalmologist, if you're age 30 and no gray hair, you may want to make sure you don't give up your manual skills also and do
of
only
course.
rely 100% on femto. You got to learn that. You have to do both.
Yes. When I started, I was thinking, like you say, because I don't want to lose my manuality, because
Right.
I do a lot of surgeries, and I was thinking like you. But well, I say I want to put every data in the femto because I want to do something in the surgery, you know.
Right.
Uh, yes, but well, I think there is a lot of cases, important cases, to do the manual surgery and to feel good and to have the manuality. But I agree with you. When you start, you need to do all of the surgery, all of the kind of surgery, also the M6, the extracapsular, to have the manuality in your hands and in your brain too, no?
For
To
sure.
learn.
Now you have a very big experience with phakic IOLs, more than in the US. So in the US, we basically only have now the Vision ICL. We don't
Hmm.
have IPCL. And in the US,
Okay.
there's no anterior chamber type lenses. Tell me about how did you go through the process? So 20 years ago, you were doing anterior chamber phakic lenses. And then how
Yes.
did it progress over 20 years?
Yes, well, I was using this kind of iOS years ago, but nowadays I start, I think 8 years ago, I started with the IPCL. And, and I started with the Model V1, that it was a little bit stronger than the Model V2. But the Model V2 is very nice because the optic are very thin. This lens have 7-hole too to
Oh,
improve
aqueous.
the humor. Yes. And well, also the IPCL have the possibility to treat the presbyopia when the patient have more than 40 years old.
Mm.
Uh, there is a version that is a Presby phakic IOL, the Presby IPCL. Well, when the patient come with more than 40-year-olds or near of the 40-year-old, I invite to use this technology to reduce the myopia, astigmatism, and presbyopia. This is also important because I don't use this phakic IOL for hyperopia because it's difficult to find the normal ACD or the normal angle. The crystalline lens increase your size and well reduce the angle, and we can have some problem. I use just for patients with myopia, but also I have some patients with emetropia that I treat the presbyopia and with very good results too. But it's not the normal patient. Uh,
Right.
to It's not the way to start with this kind of lens. I start with the myopia, but when the patient has, in some patients with emetropia, with little myopia, I use that with very good result too. But well, I think the IPCS is another option, very good option. I think I don't have any problems with the material. The biocompatibility was very good. 8 years. In 8 years, I have just one cataract with a lot of patients, well, more than 1,000. And well, also I have patients with a little volt, but without cataract. And well, this is one of the reasons that I continue using now because
Right.
the results are very good. Yes, I think it's the very good option to use in this kind of patient.
Yeah, I think the toughest patients, let's start with this. The easiest phakic IOL patients are going to be the very high myopes because you have a big
Yeah,
eye, deep anterior chamber, plenty of room. And if you take them from -16 to -1, they're going to love you.
yeah, yes, of course.
A,
All of the patients are happy.
a tough one is going to be the plano presbyope, the emetrope who's presbyopic, age 46, and doesn't want to have the reading
Mhm.
glasses. So phakic lens there with the presbyopic version may be tougher. And then I think the toughest one of all is going to be the
Mhm.
younger patients who are highly hyperopic. You get a patient who's 35 years old and a +4 hyperope. Wow, what do you do here? Now what?
Yes, yes. I think this is for me also the very difficult kind of patient to treat, no? But well, it could be an option if this kind of patient have a good anterior chamber and good angle. But uh, I don't like to use fucking IOL in this kind of patient. It's my position, no? I try to wait to talk with this patient, and I give some glasses of contact lenses or something like that. But It's not my first option to treat with hyperopia, but well, this is in my way.
Right, that's the
Well,
tough one. So, if you're young and have a little bit of hyperopia, LASIK's okay. But if you're
yes,
young
okay.
and if you're lace, if you're +4 or more, +4, +5,
Yes,
now that's too much beyond LASIK. And if you're
yes.
young, you don't want to make them pseudophakic. You don't want to do the lens replacement. So I
Hmm.
think you're right. At
No,
that age, you just stick with glasses or contacts.
for me, it's a very good option. We don't need to forget this option. We are a surgeon, but I always think if the glasses or contact lenses are the new option,
Right.
we say, well, we don't need to operate now this patient. We have this option. We have glasses now for this patient. We have contact lenses. You can change your mind too for some kind of patient and realize that you can do in another way, no? But well, I think we have a lot of options to treat this patient, but for hyperopia, I decide that glasses or contact lenses in this kind of patient, of course, with +4, plus more than +4 and young patient, of course. And sometimes it's different when the patient coming with some um, esotropia, with strabismus, something like that, and well, and they want to do the surgery because to reduce the ocular movement, and well, in this I also wait that the patient don't have more than 4, +4,
Right.
because I do the LASIK. That if not, is big trouble for me too. Yes, it's point to think, to analyze very well, because you need to take into account many things. Also, in the hyperopia, how is the curvature of the cornea? Because sometimes
Right.
it's 45 and you do the LASIK +3, but it's 48 after surgery, and maybe it's not so good. It's easier if the patient has 41, 42, and you do the LASIK with +3, no? Of course.
Yeah, I think there's an upper limit and even a lower limit for corneal curvature. When you get to the
Yes.
48, 49, 50 diopter corneas, it's not so good.
Yeah, it's not so good. No, no, no. Also, the last week I have one patient with myopia and with 38 of cornea.
Wow.
38 is so flat, and I say, well, I can reduce your your curvature because your cornea is so flat.
Right.
Maybe we have another option. In this case, I offer the IPCL to reduce the myopia. It was a very good option for this person. We need to analyze everything and well to take the best decision for the patient, of course, and this is the reason. And well, but yes, the phakic lens is amazing. Years ago, one doctor asked me, how do you um, how do you choose the size? And I say, well, I take into account the white to white. And how do you take the white to white and the measure? And I say, well, uh, I start with the digital compass or the normal compass, and after with the IOL Master, the Pentacam. But I realized that uh, 7 years ago that how is the anatomy, the place where we need to put the phakic IOLs. And I started to study the anatomy of the sulcus. Well, this is one of the things, my focus now is one of these things, no? To analyze how is the sulcus. Um, and I realized that is not just like a circle. They have many anatomical difference. And well, I I did some study and I realized that there is many patient with cyst, myopic patient with cyst. And well, this is another thing to take in account in this kind of IOLs, no? In every IOL. when the
Right.
patient have cyst, when the patient don't have cyst, and when the patient have cyst, 360-degree microcyst around of the sulcus. And where is the cyst? Sometimes it's behind of the iris, but when the cyst is in the ciliary body or in the place when we need to put the IOL, uh, hour 3, hour 9, and well, we need to take on account the size of the cyst, the number of the cyst, and well, many things to take on account of the size of this, no, the IOL, this phakic IOL.
So you must be measuring it then with UBM, ultrasound biomicroscopy. How do you measure the
Yes,
sulcus?
yes. Nowadays, I use the UVM to measure. I take 10 measurements of
Mm-hmm.
each patient, horizontal measurement, and I take an average of all of that. And I say, well, this is the average of this measure, because sometimes with the doctor that take one measure is maybe 14.2 or 13.2. If we have different, we take this average. But um, the most important thing for me is when we have some cyst in this position, no, and the size of the cyst. The cysts are sometimes reduce and change the white to white, like maybe with the IOL master, and because of the cyst. And well, I take into account all of these things. And sometimes I have some problem with the toric IOLs, the toric version of phakic IOLs, because if we have a cyst and a big cyst in this position, maybe the toric can
Oh,
rotate.
right.
And well, we need to, when I have cyst, I always put the phakic IOL if we have cyst or no cyst. But when the patient has cyst in this position, I talked before, maybe we can have some problem with the IOL and we need to change, because if I put a little bit bigger, 0.25, 0.5 more millimeters, compress the cyst,
Mhm.
the IOL don't move after that, no? But well, it's important the previous the chair time, no, that we spend with this patient.
For sure. Well, I think maybe in the future we could have a redesign, a new version of a phakic lens that has haptics. Like if we look at regular IOLs that go in the capsular bag, we know that patients have a variable size capsular bag. So we have a
Hmm.
three-piece or even one-piece IOL with haptics that have a compressibility so that you can always have a lens regardless of the patient's capsular bag size. So maybe we should have a similar design for these phakic IOLs in the sulcus, that the same lens can be adapted to a different size sulcus, even if there's let's say a cyst there in the ciliary sulcus.
Yes, yes, yes. There is many people that are thinking about that. I'm also was thinking about that. Some optic that can compress and reduce. And the
Right.
IPCL, it it has some compressive optic, but not. I think it's not enough like we are thinking to put one IOL for 12 or 14. That just change the position of the optic. No, it could be good, but I think the important thing in that case is to do this kind of haptic that don't have any damage in the sonula, in the sulcus. You know, if these haptic are moving,
For sure.
I think that many engineers are working, thinking about that. No.
For sure. Now you must also do a larger number of just cataract surgeries, because I'm sure Argentina is like U.S. or any other country where the number of cataract surgeries is much larger than the number of corneal refractive or even phakic lens surgeries.
Course. Yes. Yes, yes, yes. I do a lot of cataract surgery. It's my first surgery. that I do. And well, I think uh, I do a lot of premium cataract surgery, but I love when I have some complicated case to speak. I think 2 months ago I have one complication in what case, and I shoot one plate, toric plate, and it was an amazing challenge to do this surgery. You know, uh, well, nowadays many doctors are doing the surgery, the surgery in the sclera, and I think it's a very good option. But we don't. Uh, we need to remember always that we have some pseudophakic IOL, the artisan, and we can use and put behind of the iris, and it's very
Yes.
easy also to do that, and it's very safe too. And well, it's I know that some patient can could happen that this lens can move, but it's not the common to do that. I use
Right.
both option, depend of the patient. I like to shoot it at the sclera, but I also like to put the art design behind of the iris inverted in inverted side. No,
Yeah, that's a fantastic lens, but we don't have it in the USA. It's not FDA approved.
you don't
So
have the
now what we're talking about is the artisan lens for aphakia. So for a patient with a normal iris, but no capsular bag support, instead of doing a scleral fixated IOL, you can put this
mhm.
iris clip lens that comes in plus powers for treatment of aphakia, like plus 16, plus,
Yes,
and you can clip it to even the back surface of the iris, keep it away from the corneal endothelium. And that has great long-term success. I've seen some of these patients' videos on Cataract Coach, and it's beautiful, a great option. We just don't have it in the USA.
yes. I call the surgery 1 minute surgery without shooters.
Yeah.
Aph- Aphakia 1 minute surgery without suture because it's very easy to do. It's very safe for the patient. We you don't lose time to do the surgery. The cornea is very well because you put behind of the iris, and
Mhm.
well, I think is well. I hope that you could have this option there too. No, it's not
It,
easy.
it would be nice if we get it one day. That would be great. But who knows? But no, for a routine kind of cataract case, what are your favorite lenses now? Because oftentimes in other countries like Argentina, you will get newer lenses before we get them in the US.
Yes. Well, I have a lot of experience with one company from Israel. The name is Hanita. I
Hmm.
have more than 6,000 IOLs that I use it. Not only premium, also the aspheric version. The name is Hanita. Um, and they have all version of IOLs, toric, bifocal, and now they have one that is pentafocal. This is another technology of
Hmm.
IOLs,
I don't
pentafocal,
know this
five
one.
foci.
5 focal points.
Five, yes. The real thing is they it's a trifocal lens, but they
Okay.
have two intensifier between far and intermediate and between intermediate and near. This intensifier reduce the trifocality, and the focus curve is like very flat,
Uh,
and it's like a continuous vision, like a continuous vision. The
so
patient
instead of
feel like that.
so instead of having a peak for distance, a peak for intermediate,
Yes,
and a peak for near,
exactly.
this fills
Yeah.
in those two valleys. So it's kind of a continuous vision from near to far.
Yes, it's like that. And it's real, and the patient feels like that because the focus curve is something objective, But when I take the near letter, the patient can read here, and I put a little bit longer. And nowadays I'm doing some study with 2 years of follow-up with this IOL with very good results. And well, there is another thing that these two intensifier reduce the difference between the rings and reduce the halos too. It's
Mm,
something like a big EDOF, no? Too
like a
far,
large
too
blush.
near, too near. Yes, it's something like that. Yes, this year was presenting also in in the ECRS, but I use it from 2020, and also it has a toric version too, also with very good result too. I think this is one of the technology that I like it. And also nowadays we use a lot the monofocal plus here. Uh, there is a lot of patients that use this technology, and the patients are very happy. But always, I talked before that it's not IOL for near vision for read. It's it's a plus version. It's like a monofocal, but with the plus version. I say you can see for far and in the sign of intermediate. But it's not for read the computer or the all of the this thing. Is you can have a little bit more like see the when you drive you can read the number how is the high speed that you are in your
Yeah.
car or something like that.
Yeah, you can see the
But well,
dashboard, the speedometer, the
the
navigation. You can see
dashboard,
that. Yeah.
yes. Yes, of course, these things. But here is a very common IOL. Patient choose Many patients choose a lot because sometimes for the cost of the IOL is cheaper than the trifocal version, and what is a good option too. And also the EDOF and some EDOF I are very near of some of these monofocal plus, and
Mhm.
some of them are near to the bifocals. No, there is a new classification now that the functional classification, and I think that it's very good to realize where we are now. But I don't like to put one IOL mix and match.
No mix and match.
Monofocal, no mix and match. No monofocal plus and trifocal in another eye. No, I try to use always the same IOL in both eyes.
Right.
Um, well, I always say that we need to feel confidence to give to some advice at the patient because this is where we are feeling. I I think that is the best option to put the same IOL in both eyes. But I know many friends of mine that use different, and they are choosing one IOL, different IOL, and I'm thinking in which way they can use. Well, I think that if the doctor is feel confidence in that way, they can do that. But I like in another way to put the same IOL in both types. And I also I use a little bit micro monovision with patient, but no more than minus 0.5 or minus 0.75
A little
because
bit.
if not, yes, it's just a little bit, no more than that.
Now, of all your cataract patients, what percent are
Yes.
doing monofocal or monofocal plus? What percent do EDOF lens? What percent are doing the trifocal or pentafocal lens?
Maybe 50% of trifocal lenses.
Wow,
50%.
50. Wow,
Yes,
that's higher than I expected.
yeah, yes. I use a lot the trifocal because I like it, huh,
Right.
and I offer. This is I say that the patient do it like your feeling. No, my feeling is secure with this IOL, and I offer for all of my patients. And but yes, 50% maybe is the trifocality for me, and the other is maybe EDOF or monofocal is 40% and 10% is monofocal, the normal monofocal IOL, aspheric monofocal. No? But
So truly
yes,
refractive cataract surgery, because you're really trying to
yes,
minimize residual refractive error. You're trying to treat presbyopia and the myopia and the hyperopia and the
yes,
astigmatism, everything at once.
yes. I am a surgeon, like you say, and I always try to reduce the use of glasses. Um, I like it, and the patient, I love it. I know this kind of patient are different than the normal cataract or the high volume surgeon that do maybe 100 surgery a day, but the
Right.
hard cataracts, yes, I have the most of my patients are with the refractive, phaco-refractive surgery, no? And
Right.
also in the hard cataract, I try to use with this kind of IOL, the trifocal or bifocal, if the cornea is good, of course, if everything is good. Because I say always that it's not only important the IOL, it's important how is the cornea, how is the macula, how is
Oh,
everything to have a very good result with these trifocal IOLs, no?
for sure. I think for best results with a trifocal, even with some EDOF lenses, you want to have good ocular surface, good cornea. You want to have obviously clear capsule with no PCO, and you want to have a nice, healthy, clean macula too.
Yes, of course. Everything is important in this IOLs. Uh, and also, I have some patients that I use with the EDOF or monofocal plus. Then they say to me that, well, I have halos. I say, why? Well, I realize many of them have halos. It's not that the monofocal plus, the many of the doctors thinking that they don't have halos with the monofocal plus. You can have halo with this kind of technology because of they have a lot of the aberrations and the negative asphericity. Well, this could be one of the reasons.
Right. That's actually a very important point, is that sometimes we think that only a trifocal or multifocal lens will have glare and halo, and we think that a monofocal will have zero. But it's actually not the case, because if you read in the initial studies or the FDA trials of these lenses, even for a monofocal lens, some patients complain of glare halo at night, even with just a monofocal lens.
Even with the monofocal, yes, I agree with you. Um, yes, because we need to take care when we say this is the monofocal plus. You don't will have halo. No, it's not like that. Maybe
Mhm.
the patient can have halos, and also with the EDOF, some EDOF have more halos
Right.
than another. No, of course, this little um, thing that they have to reduce to improve the visual acuity can give some halo too. And well, also of course depend of the size of the pupils and
Mhm.
a lot of things.
Of course. I like to tell patients that the lens implant is like any other man-made body part, whether it's an artificial heart valve or artificial hip joint. Nothing is as good as being 25 years old and healthy, and you're never going to get that back again. That's gone.
Yes, yes, of course, it's like that. Yes, I say that I will take up your natural IOL that you have, but it doesn't work right now. It
Right.
is with Pacific and with something, and I will put something artificial. It's not natural. You say,
Right.
you need to adapt. It's you need to adapt. You need to adapt the new normality. Well, like we say with the pandemic, no, the new normality.
Right. And I always tell a patient, if a patient complains too much in the post-op period, I always say, why don't we go back to the operating room? I'll put the cataract back in your eye.
Yeah.
But they say, no,
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 it's
no,
okay.
no.
I'll live with this.
I
Is
don't
much.
want.
I'll stay with it.
Yeah. Yes. Well, this is another interesting thing.
Hmm.
I never take out one trifocal IOL. I
Wow.
never change because of halos, because of glare or something like that. Yes, I do some LASIK in some little myopia or hyperopia after surgery, but I never take out one trifocal lens because of halos or something like that. I think in the chair times that we spend before is very very important. No,
No,
we
for
need
sure.
to explain. We need to explain before and not justify after surgery. No.
No, for absolutely. I think that's great points. Now tell me
Yeah.
also, tell me about your meeting. So you've told me about your meeting you have in Cordoba. I have never been.
Yes.
I must go next year. Teach me about it. Tell me everything.
Yes. Well, Oftalmo Cordoba started 7 years ago. This year is the seventh time that we do this congress. This congress started with like a little Ateneo, we call, talking about some special cases. Well, we start with things like that. And after 1 2 years, come the pandemic, and with the corona, we start to do by streaming, and we have this year 2020 more than 8,000 doctors around the world that was listening this this course, and it start to be a very nice congress. Also here this year it could be just presential in person, but well, we have this year 100 doctors that are presented their topic from Argentina and 50 from another countries,
Hmm.
international doctors that come in. And well, we start we started like that. I am in this congress. I started 4 years ago. I joined the team. They invite me, and well, I joined with them. Every year I did some live surgery too, the premium
Wow.
live surgery. Sometimes with femto, sometimes with my own techniques. And well, there is another doctor that come in and do some surgery. It's a very interactive congress uh, with the doctor that are listen the topic. This year we have some specialty day to share some skill with another doctor. We have wet lab too, dry lab, wet labs. We spend there 2 days. Always is in the end of October. 20 this year is 25 and 26, and the specialty day is 24. This was specialty day this year is with surgeries to learn surgery about glaucoma, shooter, lens and sclera. I will do some special about phakic IOLs
Hmm.
to how to use, how to implant. Well, every specialty, LASIK too, corneal transplant, and this year coming ASRAF Armia to to to
Oh,
teach about keratoconus. Yes. They
yeah,
will be here.
he's fantastic. Yeah, I just was with him last weekend in Egypt at a meeting.
Yes. Oh yes. I see you in one picture. Yes. Well, it was also three Ganes
right?
2 years ago. Yeah.
So
He
tell me, and
spent also time
your meeting is in Cordoba.
in Cordoba. Cordoba is a province in the middle of Argentina. Cordoba is a very nice province. I born in Cordoba and I studied
Mm.
medicine also in Cordoba. And then I moved to Buenos Aires. It is one of the reasons because they invite me to. And well, Cordoba is a very nice province with mountains, with rivers, and also there is another part with there is a lot of farms with
Mm.
cows, with agriculture, many of the things. But well, the Congress is in the main cities of Cordoba. It's a city with 2 million people, more or less. Very nice city. It's the second city in Argentina. And well, this year we will have many specialty that uh,
Wow.
many doctors from many specialty like retina, glaucoma, cataracts, and refractive and cornea too. Well, we hope that maybe will be there more than 500 people, doctors that coming from another countries and also from all the province of Argentina, all the state of Argentina. We call here province, but it's like a state there in USA, no?
So, and your meeting also has a lot of live surgery then.
Yes, we do live surgeries. The last year was, I think, we did one day before with live surgeries. We change every year. We
Yeah.
change things. The last year was with maybe 16 surgery the previous day, and we share with by streaming. And this year we will do 2 or 3 premium live surgery. I will do one
Mm.
of them with this lens, with the intensity. And well, this is also important to share, to know how we do the surgery, and sometimes we have some special case, and we have some friend uh, together, Dr. Neto Rosatelli, that
Sure.
was operating one of the surgery with some sonula dislocation in live surgery, and well,
Wow.
it was amazing surgery. Yes,
That's
he was
that's
there.
stressful.
Yes, yes, 2 years ago, and it was very nice. Yes, I think that the live surgery is a very nice option to do in the Congress, and well, the always the doctor are happy when they see this surgery, because it's you take care, you attract, keep your attention, no?
Live surgery is always fun at a big meeting. In the US, though, in the last many years, they phased it out. It's very unusual now. It used to be very common. I used to do live surgery for Academy meeting or ESCRS meeting for the companies, but now they don't really have it much in the US anymore.
You don't have. Well, I sometimes I do some live surgery by my channel in Instagram.
Mm.
And well, I have we used to do this surgery here, live surgery. There's not many doctors, but there is some doctors that do that. Yes, and it's nice. It's nice. I used to do that,
Yeah, live surgery is
and
fun. Yeah, 20 years ago, I did live surgery in like a dozen or 20 countries. It was amazing. Fun to learn.
yes, excellent. It's very nice. Yes, it's nice. And sometimes we we need to take care, depend of the patient. But I like to show not the normal patient. I like to show different patient. This yesterday I did one with one little patient with 21-year-old with young cataract, familiar cataract, and all her family have cataract.
Ah,
Started to 15 to, well, some white cataract too, some hard cataract that I did. I do in different way to just to show how we
sure.
can approach this surgery. But in Oftalmo Cordoba also we do that. And this year we will have, I think, 2 or 3 live surgeries. And it's
That'll
very
be fun.
nice. And I,
It sounds like a great meeting.
yes, yes, it's very nice. We work when we finish the Congress, we start to work for the next
Wow.
for the next year. Yeah, yes. And sometimes we start to work before. Well, we are waiting for you for the next year.
Yeah, that would be great. And then after the Congress, you do a little wine tour from all the Argentinian Malbec wines.
Yes, yes. We have very nice wine. Now in Cordoba, also we have very nice wine, but we have 2 provinces that where we have the best wine. One is in Mendoza, and the other one is in Salta. The Mendoza is the most famous for the wines, but Salta has have also very nice wine. And well, this is a good reason to come to Argentina from the meat and wine.
There you go. Yeah, I think yeah, you should definitely encourage more international people to come to the meeting. Certainly a lot of US surgeons. You can get a nice flight, probably fly to Buenos Aires and then a short flight over to Cordoba.
Yes, it's a short. Yes. It's like that. There is a short flight to Buenos Aires to Cordoba. It's just 1 hour. 1 hour.
Okay.
The most of the flights coming like that. Yes, with 1 hour of from Buenos Aires. But there is also direct flight to Cordoba, but I don't know if from USA, but there is also directly to Cordoba too. But well, you must come and to know Buenos Aires and Cordoba, of course.
Well, we'll have to put a link to your. Do you have a website for your meeting? We can put a link in the
Okay,
podcast. Yeah.
excellent. www.oftalmocordoba.com.ar.
That AR for Argentina. Gotcha.
Yeah, yeah,
Yeah, I'll
yeah,
put a
yeah.
link on there. No, it sounds like a fantastic meeting. I'm looking forward to coming there as well, and obviously learning from you. I also want to invite you that after we have your podcast, we can show a surgical video of yours. Anything you want, you can submit it to me, and I'll get it posted for you. If you have an interesting
Okay,
case.
okay. I will send you. I will send you some videos. I did this. I think 2 weeks ago, one surgery with the phakic IOS with just 46 seconds, and I will send to just to show you with my technique. It's not important the time, but it's
Right.
important the technique because I don't use viscoelastic for the phakic IOL. I think
Oh,
it's very nice to show this search. I will send you many of my videos, and you select which one do you like it.
that will be fantastic. I look forward to receiving those. We'll put it up there because yeah, in the U.S., I think we're a little bit behind in the fake IOLs also, and I think it's just
Hmm.
now starting to get more momentum in the U.S. So those videos are popular, and it's also a
Okay.
nice. It's a really nice option for treatment of a lot of refractive errors, especially the high myopia. It's probably the best option.
Yes, I think so. Yes, yes, yes. Yeah, many patients from Asia do the phakic IOL like the first option to treat the not only the high myopia, the myopia too.
Yeah, no, for sure. I think it's a neat option.
Yes,
Fantastic.
it's very nice option. It's excellent. For me, it's excellent. I have a very good results, and well, it's very good. And we talk about presbyopia before with the phakic IOL. And is one of the important things is the patient don't bother about halos. And I think it's because of they have the crystalline lens. This is the only trifocal IOL that work together with the crystalline lens, and it's nice because they don't have halo. I think it's because of the crystalline lens maybe absorb the halos or something like that. But it's very nice option
Yeah, that's
to know.
interesting. I don't understand, but yeah, if it's just a regular IOL in a bag that's multifocal, they're going to have glare and halos. But you're saying a
Yes,
phakic lens that has multifocality with your clear
yes.
crystalline lens somehow prevents
Mhm.
glare and halo.
I think so. Yes, they don't have halos. They, this is the only one lens that work together. Trifocality with the crystalline lens, and
Yeah,
also 40-year-old. They have something of accommodation. This patient too, and it works together with accommodation, trifocality, and I also have patient with presbyopia,
yeah,
38-year-olds, and I introduced the lens maybe 3, 4 years ago. Now they are with 42, 43, from 38 to
sure.
5 years, and they are very happy and they adapt very well and never feel halos with
Hmm.
38-year-olds, and they never feel the difference of near vision. They never take bother about. No, I have a +2, +2.5 for near. They don't bother about because of the trifocal IPCL. It's coming with different addition for near vision. Uh,
Oh,
yes, from 1.5 +1.5 to 4 +4 with the step of zero point 0.5 zero
hmm,
point 0.5. And I published that. You can find in PubMed like Bianchi GR. Uh, well, it's a nice option. I have a nomogram to put that. But well, you need to have the IPCL there. Yes.
well, when we're going to learn from you, and we'll expect that nice video of the phakic lenses, and we'll put that up the day after your podcast.
Okay. Thank you. Thank you very much. I will
Oh,
send you.
my pleasure to feature that. And I want to thank you again for doing this podcast. Always fun to talk to you, learn your experience, learn about your new meeting and how you've been doing it the last 7 years. And definitely, I want to attend your meeting next year and have a good time and learn from all the speakers.
It could be great. It could be great, really great that you will be in Argentina in our Congress in Oftalmo Cordoba. We are waiting for you. We are happy and we are really anxious to have you in Cordoba in our house. Well, it could be great. Great for us. Thank you very much, Uday.
All right, my friend. Thank you again. And I want to remind our viewers and our listeners, remember, we have a podcast, a new one every single week. You can find it on Apple, Amazon, Spotify, Google, anywhere you find your podcast. You find the Cataract Coach podcast. Plus, remember, we still have a new Cataract Coach video every single day. Check it out, and we'll see you next time.